Very common thing that we come across, but we take it very lightly, deep vein thrombosis in an ICU setting. All of us are aware that venous thromboembolism exists, and it comprises from deep vein thrombosis as well as pulmonary embolism. And it's astounding that we are aware of it, but we don't take cognizance that in a ICU setting, out of every 100,000 patients, about 160 patients do develop deep vein thrombosis. And these are the type of patients that do come to the ICU. Some of them have conditions before they come in. They may have had surgery before, trauma, patients with malignancies, sepsis, immobilization. The age is a very important factor. All of us are getting a lot of heart failure and respiratory failure patients. Patients with previous history of venous thromboembolism, these are the cases that we should have an alert for us. Pregnant patients, patients on estrogens, and there are additional factors which patients acquire in the ICU. Like all of us do put in central venous lines. Patients do have sepsis, pharmacological sedation, and paralysis, and there is mechanical ventilation. This is something which I would like to stress, is that all of us are aware of this, but if you look at it, the Virchow triad, the advancing age, surgery, prior DVT, and cancer. A lot of things are there with the patient, but there is a certain thing which we can modulate, and the patient is immobile, and there are certain factors which if we use, we can help the patient. So that we know it's a preventable entity, and prophylaxis does exist. And if you look at the 2008 guidelines, which was very comprehensive, and I'm sure all of us must have gone through it, but there are certain key recommendations which have come in and which we should adopt, is that every hospital must develop a formal strategy that addresses the prevention of venous thromboembolism in their unit. And they also recommend that mechanical methods of thromboprophylaxis to be used primarily at high-risk cases who have a chance of bleeding. And these are the guidelines which came across. And there are different types of prophylaxis which we do use. And my topic is about the compression thing, which I would like to stress. If you look at the standard prophylaxis recommended in critically ill patients, where there is chance of bleeding risk in high-risk cases, it is graduated compression stockings, low molecular heparin, and the pneumatic compression. If you look at the physiology also, there's a large shift in volume with a very small pressure change. See, there is about hardly 5 to 25 millimeter of pressure change, and there's a huge volume shift. So if we can modulate this, we can give our patients in the critical care setting immense advantage. And the lower extremity muscle pumps, they have competent venous valves. The perforating veins, they prevent deep flow to superficial flow, and the calf muscle pump is the most important one. A 200 millimeter mercury pressure is generated during muscular contraction, and a volume shift of about 100 to 150 ml occurs. So this is again the slide which shows the pressure volume relationship. And the various types of compressions that do exist is the graduated compression stockings that we generally use, and the pneumatic compression which has come in of late. The common ones that were being used were up to the ankle. Now the new ones which have come up, which go up to the thigh, and they have graduated pressures, where the pressure is the maximum at the ankle, and then as we go up to the thigh, and it keeps coming down. So it helps the pumping action. What are the advantages of the mechanical compression? There's reduced pain and skin edema. It doesn't require lab monitoring. It's available for patients where pharmacological agents are contraindicated. And most important, it's an additional protective benefit when combined with pharmacological prophylaxis. While doing the net search, I came across that with stockings and without stockings, there is a definite benefit with the intermittent pressure compressions. There was this study, the CLOT2 trial, where they looked at about 3,100 stroke patients, and which demonstrated that high-length TET stockings, the anti-embolism effects, were 29% more effective in reducing proximal deep vein thrombosis when compared with knee-length TET stockings. So if you look at the new compression stockings, compression devices which have come across, they are right up to the thigh. So this can be another good modality in our ICU setting to help our patients. This again corroborates the same thing, that the pressure compression does help. So to conclude, that all ICU admissions, we must review what are our thromboembolic risks, what is the thromboprophylaxis that we are planning for, and some form of thromboprophylaxis must be started in all ICU patients except in a few exceptions. Prophylaxis must be individualized and based on each patient's risk for bleeding and thrombosis. If you look at there's a simple algorithm which I would like to pass on, is that any critical care patient which comes in for admission, assess the bleeding risk. The high risk patients, those are the ones where mechanical prophylaxis is appropriate. And if you have to delay your prophylaxis for some reason and you have to screen it, you do your venous Doppler and then go ahead. But in the other ones, the normal practice we do follow is the low dose heparin, low molecular heparin, combined anticoagulant and mechanical prophylaxis.